You're listening to ReachMD Radio on XM 160, the channel for medical professionals. Welcome to Diabetes Discourse, sponsored by Novo Nordisk, a world leader in diabetes care. Here's your host, Dr. Stephen Edelman, founder and director of Taking Control of Your Diabetes, clinical professor of medicine, Division of Endocrinology and Metabolism, University of California, San Diego, and San Diego Veterans Administration Healthcare System.
Diabetic retinopathy is the leading cause of new cases of blindness and loss of vision. However, early detection and aggressive treatment can reduce this devastating complication. Joining us to discuss diabetic retinopathy is internationally known ophthalmologist in San Diego, California, Dr. Paul Tornambe. Dr. Tornambe, welcome to ReachMD.
Thank you, Steve.
How many people with diabetes are affected with diabetic retinopathy, and what is the typical time frame in terms of developing this complication?
Well, if you've had diabetes for about 20 years and you're under fairly good control, the odds are 90% of you will have some form of diabetic retinopathy. But that's a spectrum from very minimal disease to significant disease. And so we usually tell patients that the incidence of diabetic retinopathy depends on, number one, how long they've had diabetes for the duration, and number two is how good their metabolic control has been.
What are the different categories of diabetic retinopathy? I know from many of us don't remember too much from our medical school ophthalmology rotation.
Well, basically, there are two broad categories. One is non-proliferative diabetic retinopathy, which we usually refer to as background diabetic retinopathy, which is manifested by dot blot hemorrhages, microaneurysms, exudates, and the primary reason for visual loss in these cases is retinal ischemia, or what we call macular edema. And the second type is proliferative diabetic retinopathy. In this case, the ischemia has increased to such a point that certain cytokines like VEGF are elaborated, which stimulates new vessel proliferation. They're abnormal, spider-like vessels. They bleed and hemorrhage and cause scarring and retinal detachment.
Well, I think an important question is, what kind of symptoms are patients getting during the development and progression of diabetic retinopathy from non-proliferative to proliferative?
Well, the scary thing is they may not have any symptoms. And if people have been very poorly controlled and haven't seen their eye care physicians and their medical doctors, they'll sometimes present with some floaters in one eye. An examination of both eyes will reveal extremely advanced disease. So they may have no symptoms at all. The more common ones would be floaters, which would represent vitreous hemorrhaging, or they could have generalized blurred vision, which would be a manifestation of diabetic macular edema, which may be very gradual. Those patients might also notice some distortion in their reading vision.
Any condition where there are no symptoms in the early stages really requires screening. For most of our listeners, they're primary care physicians, they may be endos. What's the recommendation for screening?
Well, for an insulin-dependent diabetic, we would recommend that they be checked 5 to 10 years after the onset of their disease. If they've developed the disease when they're 7 or 8, usually you want to check them somewhere around puberty because that's when the disease can really take off. As far as the type 2s, they should be examined at the time the diagnosis is made, shortly after that. As a matter of fact, sometimes the eye care physician will be the one who makes the diagnosis before it becomes metabolically noticeable to the patient.
Do they need to see a specialist like yourself who is a retinologist? Can they go to an optometrist who dilates the eyes, etc.?
Well, I think that the modern-day optometrists are better and better trained. And the basic findings of diabetic retinopathy, microaneurysms, hemorrhages, cotton wool spots, exudates, those can be recognized by anyone who's trained to do a dilated examination.
If you're just joining us, you're listening to Diabetes Discourse on ReachMD XM 160, the channel for medical professionals. I am Dr. Steve Edelman, and I'm speaking with Paul Tornambe about diabetic retinopathy. Paul, how can healthcare professionals help their patients prevent or reduce their chances for getting diabetic retinopathy?
Well, Steve, I think that good medical control is the primary thing that we want to see done. A hemoglobin A1C in the 6 to 7 range, good blood pressure control, checkup of any renal disease, lipid management and weight management, and then, of course, diet and exercise. But most importantly, to be sure that they are screened every year or 2 years by eye care providers, and then once the diagnosis of diabetic retinopathy is made, to have a retina specialist evaluate that patient.
I've heard you say several times when you're speaking at a lot of the patient conferences that we organize that if you get a yearly dilated eye exam, your chances of going blind are virtually nil.
Well, that's true. The only exception might be that patient whose diabetic state deteriorates very rapidly, let's say to renal failure. But for the most part, if you are in good general health, in good general control, and you have an eye exam once a year, the odds of you going blind from diabetic retinopathy become very slim.
Excellent. Walk us through what a typical retinal evaluation consists of.
When they come to our office, we always dilate them. And diabetics should know that to get a proper eye exam, they must be dilated. We then like to take fundus photographs to document what pathology is present, and we like to scan the fundus so we have as broad an area of the retina as possible documented. If there is evidence of vascular disease that's significant, we might do a fluorescein angiogram whereby we inject a very benign fluid coloring into the vein and take photographs of the eye. And then finally, if we suspect that there might be swelling of the retina, we'll do optical coherence tomography, better known as OCT.
Yeah, I know that's a relatively new way of measuring edema, which has really helped therapy. Well, let's talk about the therapeutic approaches to diabetic retinopathy from, pre-proliferative to proliferative.
Well, I think the standard therapy is laser photocoagulation, both for non-proliferative diabetic retinopathy if there is macular edema, and then for extremely advanced non-proliferative disease, we'll sometimes recommend photocoagulation there. And then we still use the National Eye Institute criteria for high risk before applying pan-retinal photocoagulation for proliferative disease.
Well, what is that recommendation?
Well, basically, if the patient has any bleeding due to neovascularization, they should have laser. That's more of an oversimplification, but in general terms, I think that holds.
Well, Paul, you've always told me that the way we treat diabetic retinopathy is pretty archaic. You're actually destroying the eyes. What are some of the side effects?
I think the first thing that's really important that the patients have to know is that this therapy has been proven in clinical trials and works. And if it's indicated, even though it may have some side effects, it is certainly better than the natural history of the disease. The major side effects of laser is loss or decrease of peripheral vision and night vision. Occasionally people will get diabetic macular edema from the laser, but that's rare. And if the laser is very extensive, sometimes there can be pupil abnormalities where the pupil is dilated. But for the most part, most diabetics will enjoy relatively good peripheral vision and central vision. They'll be able to drive, they'll be able to read, they'll be able to watch TV. There may be some loss of peripheral vision, but it's a small price to pay.
Well, I have type 1 diabetes, and you've lasered me several times, and I learned about night vision the hard way. When I went to a movie theater, I sat on this one woman's lap by accident, she's holding a bag of popcorn as well. Well, I know that you've always mentioned about our current therapy is primarily laser. Let's take this moment to talk about some exciting new stuff that you've spoken about at other conferences about what's on the horizon for preventing and treating retinopathy.
I'll tell you one thing that I think is really important. Many diabetic patients tell you that they hemorrhage when they notice the hemorrhage when they wake up in the morning. And I think a high percentage of these people have sleep apnea. So one thing that I do when I get that history from a diabetic is to ask them to see their primary care physician to arrange for a sleep study. The mainstay for proliferative disease that gets out of control is vitrectomy, where we go inside the eye, remove the vitreous jelly, and remove those blood vessels. But what we're doing now is we're using a VEGF inhibitor, usually bevacizumab or Avastin.
Well, Paul, let me interrupt. Explain what VEGF is.
VEGF is a cytokine. It stands for vascular endothelial growth factor. And this is one of the major contributors to proliferative diabetic retinopathy. It's what stimulates the blood vessels to grow, and this substance is elaborated in response to hypoxia. The reason the laser works is that it improves the oxygen state of the retina and decreases VEGF. So now what we're doing is we're injecting these VEGF inhibitors into the eye shortly before a vitrectomy, 3 or 4 days. And what this does is it basically makes the proliferative disease go into regression for about 3 months. And we can then go into these eyes and do the vitrectomy and have much less bleeding and much less postoperative complications. So this is really a major breakthrough in our management of diabetic retinopathy.
Well, when do you think this will become the standard of care?
Since we first talked about it 3 years ago, there have probably been several hundred papers presented in peer-reviewed journals talking about the advantages of Avastin. Some people are even recommending it before doing panretinal photocoagulation for very succulent vessels to minimize the chances of postoperative hemorrhaging. So I think that this is the standard of care now.
Well, I think that's so important you mention that, because our listeners are listening from across the United States and probably around the world, and it's important for them to know so they can seek out the best therapy for their patients. Well, I would like to thank our guest, ophthalmologist in San Diego, California, Dr. Paul Tornambe. Dr. Tornambe, thanks so much for spending time with us on Diabetes Discourse.
My pleasure, Steve.
Thank you for listening to Diabetes Discourse, sponsored by Novo Nordisk, a world leader in diabetes care. To learn more about diabetes and the role of GLP-1, visit novomedlink.com/DIA. For more details on the interviews and conversations in this week's show, or to download the segment, visit us at reachmd.com.
Daddy, what are you reading?
I'm reading about something called GLP-1.
Is it a robot?
No. GLP-1 is a natural hormone that helps regulate glucose metabolism. Its multiple actions are critical to glucose control.
Huh?
Okay. Well, GLP-1 works in a glucose-dependent manner. It stimulates the beta cells in your pancreas to secrete insulin and inhibit the liver from releasing excessive glucose by reducing glucagon secretion from alpha cells. It also helps regulate food ingestion by slowing gastric emptying in your stomach here and making you feel full.
Like at Thanksgiving?
Yes.
I don't get it. Is it important?
Well, GLP-1 is important because it impacts the multiple systems affected by diabetes. It also plays a significant role in protecting beta cells, a key to slowing diabetes progression. Unfortunately, many people with type 2 diabetes have impaired GLP-1 secretion and impaired beta cell response to GLP-1.
Like Grandpa?
Yes, and like many of my type 2 diabetes patients. That's why I want to make sure I'm looking at the whole picture in diabetes. Sustained control of A1C is important, but we can't stop there. It's important to look at weight, cardiovascular risk, and beta cell dysfunction. Impaired GLP-1 physiology is also a part of the problem, and the multiple actions of GLP-1 throughout the body are critical.
So, the GLP-1 robot will help you see the whole picture.
Yes, I guess, in a way, it will. Novo Nordisk is a world leader in diabetes care and is dedicated to ongoing research. To learn more about GLP-1 and the role it plays in diabetes, please visit novomedlink.com/DIA.